Sandy, I mean, one of the things that we're understanding in oncology is we're looking for activating mutations anywhere we can find it. Sometimes we look in the tissue, and most recently we're now looking in liquid biopsies. Is there a role for liquid biopsy testing in your practice for kidney cancer, and what would you recommend for the practicing physician in the community?
I think in general, this is a very confusing topic for most community oncologists. We do both the foundation one with as well as the Guardant liquid biopsy, and I think interpreting those reports can be challenging. I think that they are really prognostic at this time. They tell us that a patient might do better or worse, but they're really not helpful in selecting which drug to give for a given patient. I would advise community physicians that perhaps referral to an academic center for a molecular tumor board, which is sometimes what I do. I take that report and give it to our tumor board, especially to help us advise what the next steps that we could do for a given patient.
And do you do that at the time when a patient is progressing, or at diagnosis, or where in the course of a patient's disease do you think it's most helpful?
Well, it's interesting. We get people coming in with this report, so sometimes it's not my choice in ordering the test. So that's one way that we have to help advise the patient what to do. But if it were my choice right now in 2017, I probably wouldn't do it in every patient. I wouldn't do it for a patient coming in for first-line therapy, but looking more when I run out of options, considering this patient perhaps for a matched clinical trial. That's a setting in which I would use these tests.
And Michael, let me ask you, I mean, we talk mostly about clear cell renal cell carcinoma, but there's a whole other group of patients with non-clear cell histologies. Do you find these approaches, and at the 2017 ASCO meetings, there were actually some abstracts about the TCGA analysis of non-clear cell histologies. Do you differentiate when you apply this in your practice?
Well, first of all, in my practice, I'm usually, if I'm treating someone off protocol with a VEGF inhibitor, I'm usually not going to be doing genomic testing on them, because most clear cell kidney cancers have VHL loss and are driven by VEGF, and therefore you're going to choose a VEGF inhibitor as your first line of therapy in standard of care no matter what. And only if I see an unusual lack of response to a VEGF inhibitor do I start looking for something else that might be driving a clear cell tumor, like the rare tumors that are driven by PI3 kinase, mTOR, tuberosclerosis pathway, where you might decide on second line that you would give a TOR inhibitor. In addition, one gene that we've looked at, and it hasn't been fully validated prospectively yet, is p53 mutations, which are relatively uncommon in kidney cancer. And in our view, that's actually one of the reasons why kidney cancer is susceptible to VEGF inhibitor therapies as a single agent. It's one of the few cancers where single agent anti-VEGF therapy is effective. And that's because when p53 is wild type, the tumors that get acutely hypoxic when you give them a VEGF inhibitor are not able to survive that hypoxia as well. And we found in some preclinical models and then some retrospective analysis of patient specimens that patients who have p53 mutations are less likely to be responsive to VEGF inhibitors. And as it turns out, they're probably more common to have p53 mutations in metastatic disease than in the primary tumors. So it gives you a reason to potentially biopsy a metastatic lesion if that's a factor in your decision making and not just rely on the primary. But for non-clear cell cancers, which we were talking about, the only thing that is really similar about them is that to clear cell is that they're in the kidney. They have different mutations that tend to drive them, at least in their hereditary forms, and they're not really as responsive to the treatments that we use for clear cell cancer they're not that responsive to those treatments, and they're not any more responsive than maybe another tumor in another organ. Unfortunately, we don't have good therapies for most non-clear cell cancers, so we're forced to either use those same therapies or put patients on clinical trials.